When we look at the dashboard of human health, there are, well, there are just a few metrics we take completely for granted.
Oh, absolutely. We barely even think about them.
Right. Like you sit on that crinkly paper at the doctor's office, they wrap the cuff around your arm, it squeezes, beeps, and just spits out two numbers.
Yeah. And most of us, especially if you're tracking your cardiovascular fitness, you just glance at those numbers.
Exactly. You categorize yourself as, like, safe or at risk, and you just move on.
Which is a huge oversimplification.
It really is.
Hmm.
So today, we are going to tear that dashboard apart and actually look at the engine. We're taking a deep dive into the physics, the history, and the, frankly, mind-bending quantum reality of blood pressure.
It is a fascinating topic, and we have a massive stack of source material to get through today.
We really do. I mean, we're looking at everything from Western medical handbooks and historical archives to cutting-edge physics papers on quantum hemodynamics.
Yeah, plus clinical studies tracking the stress levels of military pilots and even comprehensive analyses of traditional Chinese medicine.
It's a lot of ground to cover. But our mission today is to look at the exact same biological phenomenon, the pressure of fluid in your vessels, from these entirely distinct vantage points. We really want to understand the why behind cardiovascular health for you, the listener.
And the value of synthesizing these distinct perspectives is that it completely reframes what those two numbers actually mean.
Right, because it's not just a mechanical thing.
Exactly. We have to shift away from the idea that blood pressure is just a rigid mechanical readout.
So understanding the underlying mechanisms, like how your brain actively defends its own blood supply, that changes everything.
It does. When you see how your psychological state fundamentally alters your vascular resistance, or how the electrical impulses driving the entire system rely on subatomic particle tunneling,
Which is still just wild to me.
right? But when you grasp that, you gain a much more profound, actionable understanding of your own physiology.
Okay, so let's bypass the elementary definitions here. I mean, we all know the cuff measures the systolic force of the heart contracting and the diastolic resting phase.
Yeah, everyone knows the basics.
But the clinical handbooks in our stack, they focus heavily on mean arterial pressure, or MAP, combined with systemic vascular resistance. They treat those as the true drivers of the cardiovascular system.
Because it's not just about how hard the pump is working, it's really about the friction the fluid encounters along the way.
And that friction is the critical variable, right?
Oh, absolutely. As blood leaves the massive elastic aorta, it branches into smaller and smaller arteries until it reaches the arterioles.
The resistance vessels.
Exactly. They are heavily innervated by the sympathetic nervous system and wrapped in smooth muscle.
So this is where the profound drop in pressure occurs.
Yes, this is where the body exerts its moment-to-moment control over systemic resistance. I mean, the heart generates the flow, sure, but these arterioles generate the pressure by actively resisting that flow.
And the whole system is constantly fighting against the physical reality of gravity, which is something we don't really think about.
We take gravity for granted, yeah.
The medical handbooks draw a great parallel to municipal plumbing. Like, a household water supply needs sufficient hydrostatic pressure from the main line just to push water up to a second floor shower head.
Right, against the pull of gravity.
Yeah. So your cardiovascular system requires a baseline pressure just to propel oxygenated blood from the left ventricle up into the cerebral cortex.
And the body handles this gravitational challenge beautifully. It uses these things called baroreceptors, which are primarily located in the carotid sinus and the aortic arch.
And those are basically pressure sensors.
Well, actually, they're mechanoreceptors. They don't detect pressure directly. They detect the mechanical stretch of the vessel wall.
Oh, interesting. So how does that work when you stand up?
So when you move from lying down to standing up, gravity pulls blood down, right? It pulls into your lower extremities.
Right, which means less blood going back to the heart.
Exactly. Venous return drops, cardiac output falls, and the stretch on those baroreceptors decreases.
And then the alarms go off in the brain.
Basically, yeah. Within milliseconds, they decrease their firing rate to the brainstem. That immediately inhibits parasympathetic output and ramps up your sympathetic tone.
So your heart rate accelerates.
Yes, and those arterioles we mentioned, they constrict tightly to preserve flow to the brain so you don't pass out.
It's just an exquisitely tuned, closed-loop feedback system.
Mm-hmm.
Yet when we look at the historical archives in our sources, it is staggering how long it took the medical establishment to even recognize this system existed.
Let alone figure out how to measure or treat it.
Yeah, the timeline here is fascinating. I mean, we don't get a working model of circulation until William Harvey in 1628.
And his methods were
Oh, well.
Yeah, his methods for observing this pressure were, to put it mildly, pretty gruesome.
They definitely were. His seminal work, De Motu Cordis, relied heavily on direct anatomical observation rather than theoretical philosophy, which was the standard of the time.
Because before that, it was all Galen's theories.
Yeah.
Right. Galen thought blood just sort of slowly oozed or was consumed by the tissues, but Harvey observed amputations and tumor resections.
Oh, wow.
Yeah, and he noted that blood would literally jet from the severed arteries in a pulsatile rhythm that matched the heartbeat.
So that was the empirical evidence that blood was being driven under significant continuous mechanical pressure by the heart acting as a pump.
Exactly. It wasn't just oozing, it was pressurized.
But the first actual measurement of this force didn't happen until over a century later, right? With the English clergyman Stephen Hales in 1733.
That's right. And he essentially created a vertical manometer.
Using a horse.
Yes, by inserting a brass pipe into the carotid artery of a horse, connecting it to a glass tube, and just watching the column of blood rise.
That is wild. He directly measured the hydrostatic pressure.
But then it's Richard Bright in 1836 who starts connecting this mechanical force to systemic disease.
Bright's observations were crucial. He observed cardiac hypertrophy, so the physical thickening of the heart muscle in patients who also had severe kidney disease. Right, which laid the groundwork for understanding hypertension as a systemic pathology.
Initially, the medical consensus was that the enlarged heart was causing the kidney damage.
But then diagnostic tools improved. We get Scipione Rivaracci inventing the inflatable cuff in 1896.
And Nikolai Kurokov describing the acoustic sounds of vascular compression in 1905.
Which is what doctors still listen for today. So physicians finally realized that elevated pressure existed independently of kidney failure.
Right. The thickened blood vessels were a widespread systemic adaptation to a higher driving force.
Which leads us to the historical treatments, and this is where the medical archives get incredibly dark.
They really do. Before modern pharmacology, physicians were essentially treating a closed hydraulic system with no pressure relief valve.
So they resorted to mechanical drainage. I mean, bloodletting and leeches were standard protocol.
Yeah, for what they called the hard pulse disease. They were trying to physically reduce the stroke volume.
And later, even in the 20th century, we see the Kempner-Rice diet.
Oh, that was extreme. It was this monotonous regimen of just rice and fruit.
Basically a brutal form of sodium starvation, right?
Exactly. It was mechanically forcing the body to excrete fluid and lower blood volume.
They also utilized surgical sympathectomy.
Yes, where surgeons would physically sever the sympathetic nerve chains running alongside the spine.
Just to force the blood vessels to remain dilated. That is terrifying.
They would even inject pyrogens to artificially induce a fever.
Wait, fever to lower blood pressure?
Yeah, because the peripheral vasodilation caused by the body attempting to radiate heat would temporarily lower systemic blood pressure.
Wow. It was a desperate era of medicine. They were relying on physiological blunt force trauma to lower numbers, up until the introduction of oral diuretics like chlorothiazide in 1958.
Which finally changed the game.
But this narrative arc reveals a massive ongoing controversy in the medical literature regarding the shifting goalposts of diagnosis.
This is a huge point of debate.
Because we assume the current guidelines are absolute biological truths. But the archives show a completely different philosophy just a few decades ago.
Right. In 1911, Eberhard Frank coined the term essential hypertension.
And the prevailing theory back then was that as humans age, our arteries naturally stiffen due to atherosclerosis.
Therefore, a higher blood pressure is biologically essential to force blood through these rigid pipes and maintain organ perfusion.
Yeah, the clinical texts from the early to mid-20th century reflect this belief really strongly.
You can find quotes from prominent cardiologists like Paul Dudley White in the 1930s cautioning against interfering with hypertension.
Because he viewed it as a necessary compensatory mechanism.
Exactly. And Charles Friedberg's 1949 textbook, Diseases of the Heart, actually classified blood pressures up to 210/100 as mild benign hypertension.
Mild benign.
He argued it didn't even warrant medical intervention.
That is just mind-blowing. I mean, to put that in perspective, a patient presenting with 210/100 today would be immediately evaluated for hypertensive crisis.
Oh, they'd be sent to the ER immediately.
So the paradigm shifted radically following the Framingham Heart Study and actuarial data in the 1960s. That demonstrated a clear, linear relationship between higher pressures and increased risk of stroke and heart attacks.
And so the goalposts began marching downward.
Right, culminating in the 2017 guidelines from the American College of Cardiology and the American Heart Association. They lowered the threshold for diagnosing stage 1 hypertension to 130/80.
And this reclassification is heavily debated within the sources we are analyzing today.
Yeah, the controversy centers on the concept of tissue perfusion,
Mm.
particularly in the elderly.
Because the guidelines champion an aggressive lowers better approach based on large population averages.
However, the data on frailty suggests a profound paradox. Aggressively medicating frail, elderly populations to meet these new, lower targets often results in higher mortality.
The specific study cited in the material looked at adults aged 85 and older with mild frailty.
And the numbers are shocking. The data showed they were 39% less likely to die over the study period if their systolic pressure was elevated to the 170 to 179 range.
Right. But if they were medically treated to force their systolic pressure down into the recommended 130 to 139 range,
Their mortality risk spiked. They were 66% more likely to die.
it forces us to really reevaluate the mechanical reality of the aging cardiovascular system.
So as arteries calcify and lose their elasticity, the resistance to flow increases massively.
Exactly. The heart must generate a higher driving pressure, a higher MAP, just to ensure that highly metabolic organs receive adequate oxygen.
Let's apply a mechanical analogy here to clarify the mechanics of perfusion because I think it helps. Think of an older, heavy-duty vehicle.
Okay.
Over time, the internal oil lines become narrow and rigid with buildup. As a result, the oil pressure gauge on the dashboard is going to read significantly higher than when the car was new.
Makes sense.
The pump is working overtime to generate the pressure required to force the viscous oil through those compromised lines to lubricate the vital engine blocks.
Right.
If a mechanic simply looks at the dashboard, decides the number is abnormal compared to a brand new car, and installs a regulator to decrease the pump's output, they haven't fixed the pipes.
They've simply deprived the engine of lubrication.
Exactly.
Yeah.
In a human, the high pressure is often a necessary compensation for a degraded vascular network.
And the physiological consequences of lowering that pressure artificially are severe.
What happens?
Well, when you aggressively drop the MAP in a patient with stiff arteries, you risk hypoperfusion.
So, not enough blood flow.
Right. The kidneys fail to filter toxins efficiently, leading to acute kidney injury. And more critically, cerebral perfusion drops.
The brain doesn't get enough blood.
Yes. The patient experiences orthostatic hypotension, dizziness, and a high risk of falls.
Which in an 85-year-old often leads to a hip fracture, which we know is a major catalyst for mortality.
Yes.
Now, the vulnerability of the brain to these pressure fluctuations brings us to the next layer of our source material. The brain is the ultimate physiological VIP, right?
Oh, without a doubt, it consumes a massive amount of our cardiac output and oxygen.
And it cannot tolerate ischemia for more than a few minutes. So how does it dynamically defend itself when systemic pressure is fluctuating so wildly?
Well, the anatomical defense is brilliant. At the base of the brain, we have what's called the circle of Willis.
Okay, what is that?
It is an anastomotic ring, a circular network of interconnecting arteries.
Oh, so it's literally a circle of pipes.
Yeah. The internal carotid arteries supply the anterior portion, and the vertebral arteries supply the posterior portion, and they all meet in this loop.
So what's the functional significance of that?
Redundancy. If one of the primary feeding arteries develops a slow occlusion, maybe from an atherosclerotic plaque, the pressure differential allows blood from the other major arteries to flow around the circle.
Even backwards.
Yes, retrogradely if necessary to preserve flow to the compromised hemisphere.
That is incredible. But beyond the physical layout of the pipes, the sources introduce a fascinating biophysical concept regarding how the brain's microvasculature manages flow beat to beat.
You're talking about critical closing pressure, or CRCP.
Right, CRCP. What exactly is that?
CRCP is a parameter used to model the hemodynamics of the cerebral bed. It is defined as the theoretical level of arterial blood pressure at which cerebral blood flow ceases completely.
See, the intuitive assumption would be that flow stops when pressure hits zero. Like, if there is no driving force, the fluid stops moving.
That's what you would think.
Yeah.
But the physiological reality is that the pressure required to maintain flow is significantly higher than zero.
And our sources highlight a detailed study from the Institute of Physics in Sri Lanka that physically measured this phenomenon in living human subjects.
Yeah, the Sri Lanka study analyzed 59 individuals. They divided them into young normotensives, elderly normotensives, and elderly hypertensives.
And what did they find?
They discovered that across all these groups, the critical closing pressure hovered around 34 to 35 millimeters of mercury.
Wait, so if systemic arterial pressure were to drop to 30 millimeters of mercury, even though there is still positive pressure in the system, blood flow to the brain would just halt.
Completely halt. Yes.
Let's break down the mechanics of why that happens.
Yeah.
Because it's kind of like taking a standard garden hose and putting a sharp kink in it, right?
That's a perfect analogy.
Water stops flowing out of the nozzle. You haven't turned the spigot off the house. There is still significant water pressure building up right behind the kink.
Right.
But the fluid flow stops because the internal pressure dropped below the mechanical force needed to overcome the physical resistance of the bent rubber.
Exactly. And the vessels in the brain possess their own inherent vasomotor tone, like a resting tension.
Okay.
The CRCP represents the exact tipping point where the driving arterial pressure is no longer sufficient to overcome that tension, causing the vessels to physically collapse.
And the methodology the researchers used to measure this dynamic in a closed human skull. It's a triumph of modern biomedical engineering.
It really is. They utilize transcranial Doppler ultrasound.
How does that work without, drilling a hole in the skull?
By placing high-frequency ultrasound probes over the temporal bone windows, they can actually bounce sound waves off the red blood cells moving through the middle cerebral artery.
That's amazing.
Yeah, and this calculates the velocity of the blood flow in real time.
So they are mapping the speed of internal cerebral blood flow continuously, beat by beat.
Exactly. And simultaneously, they utilize continuous photoplethysmography, which is typically an infrared sensor cuff placed on the finger to measure the instantaneous changes in arterial blood pressure.
Oh, so they're getting both sets of data at the same time.
Yes. By syncing these two data streams, they can plot the relationship between the driving pressure and the resulting velocity throughout a single cardiac cycle.
And when they extrapolate the line of that relationship down to the point where velocity reaches zero,
Yeah.
they find the critical closing pressure.
You got it. And what's particularly revealing about the data is how it redefines vascular resistance.
Because traditionally, cerebrovascular resistance is calculated as just a simple ratio, right? I mean, arterial pressure divided by blood flow velocity.
Right. But the researchers assert that this is an overly simplistic model that treats the brain's arteries like rigid glass tubes.
Which they obviously aren't.
No, they aren't. Instead, they advocate for a metric called the resistance area product, or RAP.
RAP. Okay, why is that better?
Because it separates the active and passive components of the vascular bed. By factoring in the critical closing pressure, RAP allows researchers to determine if a change in blood flow is due to the arteries passively stiffening due to age or disease.
Or if they're actively, dynamically narrowing their diameter through smooth muscle contraction.
Exactly, which is a process regulated by metabolic factors like carbon dioxide levels.
The study found that while the elderly hypertensive patients had drastically higher systemic MAP, their critical closing pressure remained relatively stable compared to normotensives.
Yes, which proves that the brain's microvasculature has powerful, independent autoregulatory mechanisms that operate entirely separately from the large systemic arteries.
That is just incredible. Okay, so we've spent a lot of time analyzing the classical physics of this system: hydrostatic pressure, resistance, vessel diameter.
Right, the macroscopic realm of fluid dynamics.
But the source material takes a dramatic turn here. We have a research paper titled Quantum Hemodynamics from the Innovation Laboratory of Terahertz Biophysics.
This is where it gets truly mind-bending.
It really does, because it shifts our perspective from the macro level of arteries down to the subatomic level of the cells driving the heart.
To bridge this gap, we have to look at the fundamental catalyst for the heartbeat.
The electrical signal.
Yes, the mechanical squeeze of the myocardium is triggered by an electrical action potential.
And how does that signal actually move?
This electrical signal propagates across the heart tissue when charged ions, predominantly sodium, potassium, and calcium flux rapidly across the cardiac cell membranes.
And they do this by passing through highly specialized transmembrane proteins called voltage-gated ion channels.
Exactly.
The specific channel the research focuses on is the voltage-gated sodium channel, designated as NaV 1.5.
Right. These channels are responsible for the massive rapid influx of positive sodium ions that initiates the depolarization phase of the cardiac action potential.
It's the spark that starts the mechanical engine.
It is, and these ion channels are extraordinary biological structures. They possess a selectivity filter at their narrowest point.
Which is, what, roughly the width of a single atom?
Yes, and this filter must perform a seemingly contradictory task. It must be incredibly selective, permitting only specific ions like sodium to pass, while completely excluding slightly larger or even similarly sized ions.
But at the same time, it has to allow these selected ions to flow through at massive, life-sustaining rates.
Exactly. And this is where classical physics utterly fails to explain human biology.
Yeah, the researchers outlined what they call the paradox of classical physics regarding ion channel conductance.
Because if we model these proteins using classical molecular dynamics and standard thermodynamics, the math just falls apart.
Right. To achieve strict selectivity, the channel must create a deep potential energy well.
Which is basically a high energy barrier that wrong ions simply do not have the kinetic energy to overcome.
However, according to classical theory, if this energy barrier is high enough to block the wrong ions, it should also drastically impede the flow of the correct ions.
Yes, this phenomenon is known as Arrhenius suppression.
So when biophysicists run classical supercomputer simulations of these channels relying purely on Newtonian physics, the calculated rate of ion flow, the conductance, is pitifully low.
Pitifully low. For a standard potassium channel model, the classical prediction yields a conductance of about 9.2 picosiemens.
So classical physics dictates that the channel should only allow a slow trickle of electrical current.
But when researchers measure the actual conductance of a living biological channel in a patch clamp experiment,
The real-world flow rate is around 118.6 picosiemens.
right, it is operating at over an order of magnitude faster than the laws of classical thermodynamics permit.
If the heart had to rely on classical physics, it would stall out entirely due to a lack of electrical current.
It absolutely would. So the paper introduces a non-perturbative quantum transport framework to resolve this paradox.
Quantum physics to the rescue.
Exactly. The researchers posit that at the subatomic scale of the selectivity filter, we can no longer treat these ions as classical particles.
Like solid billiard balls attempting to roll up and over a steep physical hill.
Right. Instead, we must account for their wave-particle duality. The ions act as delocalized wave packets.
Let's use an analogy to visualize this wave-particle duality and how it solves the conductance issue.
Go for it.
If you think of the ion as a solid particle, like a baseball thrown at a thick brick wall, it simply bounces off. It lacks the kinetic energy to smash through the barrier.
Right, classical physics.
However, if we understand that matter at this scale also behaves as a wave, we can liken it to a sound wave. If you shout at that same brick wall, the sound wave doesn't just bounce off, it propagates through the dense medium of the wall.
And the vibration can be detected on the other side. That is an excellent way to conceptualize it.
Yeah.
In quantum mechanics, this is known as quantum tunneling. The ion's wave function penetrates the classically forbidden energy barrier of the closed channel gate.
So it doesn't jump over the barrier.
No, the ion doesn't acquire the energy to go over the barrier. Rather, there is a statistically significant non-zero probability that the wave packet will simply materialize on the other side of it.
So these sodium ions are literally tunneling through the solid molecular structures of the heart cell membranes.
Yes, teleporting, basically.
And when the researchers factored this quantum tunneling probability into their mathematical models, the calculated conductance skyrocketed from the classical 9.2 picosiemens and perfectly matched the biological reality of 118.6 picosiemens.
It is stunning. And the mathematics of this process are highly specific. The probability of ions successfully tunneling depends on three main variables:
HR.
the mass of the particle, the spatial length of the gate or barrier, and the absolute height of the energy barrier.
Okay.
Because the barrier inside the NaV 1.5 channel is extremely thin, it allows for a high probability of tunneling.
Crucially, the researchers note that this allows the vast, statistically abundant population of low-energy ions, those defined by the thermal Boltzmann distribution that normally wouldn't have the kinetic energy to participate, to successfully cross the membrane.
Yes, and that drives the massive net electrical current required to beat the heart.
It fundamentally changes how we view the cardiovascular system. I mean, the heart is not just a pump. The ion channels are highly evolved mesoscopic quantum conductors.
They are, but the research paper also details a severe biophysical vulnerability to this quantum reliance.
Right, specifically regarding a condition called acidosis.
This is where the quantum mechanics translate directly into clinical pathology. The human body tightly regulates blood pH between 7.36 and 7.44.
And if systemic pH drops below 7.36, a state of acidosis occurs.
Exactly. At a molecular level, this means there is an abnormally high concentration of free hydrogen ions circulating in the blood.
And a hydrogen ion is essentially just a bare proton.
Right. And going back to the tunneling variables we just mentioned, the mass of the particle is a massive factor.
Protons are incredibly light. I mean, they have a fraction of the mass of a sodium ion.
Right. So according to the data in the paper, because of their minute mass, protons have an astonishingly high tunneling probability.
Wait, how high?
Their quantum permeability is calculated to be 252 times greater than that of a sodium ion.
Wow. That creates a catastrophic electrical leak.
It really does. During severe acidosis, this swarm of highly permeable protons approaches the NaV 1.5 cardiac channels.
Even when the activation and inactivation gates of the channel are physically and classically closed to prevent sodium flow?
Yes, the protons easily quantum tunnel right through the blocking structures.
They bypass the security system completely.
Exactly. And because protons carry a positive charge, as they flood into the intracellular space through this quantum leak, they systematically alter the resting electrical voltage of the cardiac cell.
Ah, so the influx of positive charge depolarizes the resting membrane potential.
Right. The cell is pushed closer and closer to its firing threshold until it spontaneously triggers an action potential at the wrong time.
This is the exact quantum mechanism that leads to lethal acidosis-induced cardiac arrhythmias, fibrillation, and sudden cardiac arrest.
The implications of this are staggering. If acidosis-induced arrhythmias are fundamentally a quantum tunneling problem, it completely shifts how critical care medicine should conceptualize intervention.
And the researchers calculate that these subatomic tunneling events occur incredibly fast, on the timescale of 3 to 7 picoseconds.
A picosecond is 1/1,000,000th of a second. Oscillations at this time scale correspond directly to the terahertz frequency range of the electromagnetic spectrum.
So they propose a theoretical application based on this data, right?
They do. They suggest that in the future, it may be possible to use targeted terahertz radiation to non-thermally interact with these wave packets.
By matching the resonant frequency of the tunneling ions, we could theoretically tune the conductance of the channels.
Exactly, modulating the heart rate and blood pressure without relying on chemical pharmacology.
From the macroscopic mechanical pressure of the cerebral arteries down to tuning the quantum resonance of protons, it highlights the sheer complexity of the cardiovascular system.
It is incredibly complex.
But there is another entirely distinct vector we have to explore which heavily influences both the macro resistance and the microelectrical state. Human psychology.
Oh, this is a huge component.
Yeah, how does our perception of our environment alter the biophysics of our blood pressure?
The interface between the mind and the vascular system is primarily mediated by the hypothalamic pituitary adrenal axis, the HPA axis, and the autonomic nervous system.
Okay, so when the brain perceives a stressor, it triggers a cascade of neurochemical events.
Right. The amygdala signals the hypothalamus, which activates the sympathetic nervous system, flooding the bloodstream with catecholamines like epinephrine and norepinephrine alongside cortisol.
We commonly know this as the fight-or-flight response.
Exactly. And these neurotransmitters bind to adrenergic receptors on the heart, increasing the force and rate of contraction, the cardiac output.
While simultaneously binding to receptors on the smooth muscle of those tiny arterioles we discussed earlier, causing them to clamp down and sharply increase systemic vascular resistance.
Yes. To examine how this stress response can be manipulated, our sources include a highly specific clinical trial observing candidates undergoing military pilot selection.
Talk about high stakes.
Absolutely. This is an environment engineered to produce extreme psychological and physiological stress. The candidates are facing rigorous evaluations that will determine their entire career trajectory.
The methodology of this study provides some incredible insights. The researchers selected 2 distinct cohorts, right?
Right, 102 candidates who had been diagnosed with hypertension and a control group of 108 candidates with normotensive blood pressure.
The goal was to determine if targeted psychological interventions could allow the hypertensive group to lower their blood pressure sufficiently to pass the strict medical screening required for flight training.
And the hypertensive candidates were further divided into subgroups. One group received standard relaxation therapy.
And the second group.
A second group received relaxation therapy combined with cognitive behavioral training designed to help them reframe their stress response.
And the third group served as the hypertensive control. The interventions were administered over a set period leading up to the final medical evaluation.
The outcome data presents a fascinating paradox.
Yeah, both of the intervention groups achieved a statistically significant reduction in their systolic and diastolic blood pressure compared to their baselines.
With the combined cognitive and relaxation therapy proving the most effective.
Right. A large portion of them successfully managed their vascular resistance and actually passed the medical screening.
But here's the twist. When the researchers analyzed the psychological exit surveys, they found that anxiety levels had actually increased across all the groups.
Even the successful ones.
Yes, including the successful intervention cohorts post-intervention.
It seems entirely counterintuitive. We've established that anxiety and psychological stress drive the sympathetic nervous system to increase blood pressure.
Right. So how could the candidates report peak levels of anxiety while simultaneously demonstrating a significant drop in their objective blood pressure readings?
We have to look at the context of the situation versus the physiological tools they were given.
Exactly. The situational stress, the impending high-stakes pilot selection test, was a fixed variable. It was unavoidable.
And as the test date drew closer, their conscious, self-reported anxiety naturally escalated. They were hyper-aware of the stakes.
However, the interventions equipped them with protocols to manually override the downstream autonomic response to that anxiety.
The mechanism of this manual override is best explained by the Byrne framework discussed in the clinical literature, which categorizes integrative interventions into behavior, exercise, relaxation, and nutrition.
And the relaxation component, which typically involves diaphragmatic breathing, biofeedback, or progressive muscle relaxation, works by actively stimulating the vagus nerve.
The vagus nerve is the primary highway of the parasympathetic nervous system, the rest and digest counterbalance to the sympathetic fight-or-flight state.
Right. So when these pilot candidates engaged in their relaxation protocols, even while consciously feeling anxious about the test, the mechanical act of slow, deep breathing stimulated vagal tone.
And this increased parasympathetic activity triggers the endothelial cells lining the blood vessels to release nitric oxide.
Nitric oxide is a potent endogenous vasodilator. It diffuses into the surrounding smooth muscle cells of the arterioles and forces them to relax.
Increasing the systemic vascular resistance.
Exactly.
This reveals a critical distinction for anyone trying to manage stress-induced hypertension. You don't necessarily have to eliminate the emotion of anxiety to manage the physiological fallout.
That's a huge point. You can't just tell a pilot candidate or a stressed corporate employee to simply stop worrying.
It doesn't work.
No, but you can train the body to physically break the chemical chain reaction. The deep breathing releases nitric oxide, forcing the pipes to dilate, essentially bypassing the conscious brain's panic signals.
It underscores the importance of physiological processing over pure emotional suppression. In fact, the source material explicitly identifies alexithymia as a significant risk factor for the development of essential hypertension.
Alexithymia is a subclinical psychological construct characterized by the inability to identify, process, and express emotions.
So individuals who heavily repress their stress, who adopt a stoic exterior and refuse to acknowledge their anxiety, are actually doing catastrophic damage to their vascular system.
Because while the conscious mind is ignoring the stress, the amygdala is still perceiving the threat.
The HPA axis is still firing.
And the arteries are chronically constricted. The body continues to keep the score, resulting in sustained elevated blood pressure.
The necessity of processing this emotional and physical stress leads us directly into the systemic philosophies of traditional Chinese medicine, or TCM, detailed extensively in our source stack.
And transitioning from Western allopathic medicine to TCM requires a fundamental shift in diagnostic logic.
Yeah, because in the Western models we've discussed, hypertension is an isolated mechanical issue, stiff pikes or overactive sympathetic nerves.
But in the TCM framework, hypertension is not recognized as a standalone disease entity. It is viewed as a symptom of a broader systemic imbalance.
Typically categorized under the syndrome of vertigo and headache.
Right. The foundational principle in TCM cardiovascular theory is that the heart, referred to as Shin, governs the blood and the blood vessels.
However, the pathology of high blood pressure rarely originates solely in the heart itself.
No, the clinical analyses in our sources point to several core systemic dysfunctions, primarily involving the liver and kidney organ systems, conceptually speaking.
One of the primary diagnostic patterns identified for hypertension is yin deficiency and yang hyperactivity.
Let's break down the mechanics of this from a TCM perspective. Yin represents the cooling, anchoring, and fluid elements of the body's energy.
And yang represents the heating, active, kinetic energy.
Right. They're supposed to exist in a dynamic equilibrium.
When an individual experiences chronic stress, overwork, or emotional stagnation, the exact scenarios that drive the HPA axis in Western terms, they gradually deplete their foundational yin energy.
And without sufficient cooling yin fluid to anchor and balance it, the yang energy of the liver becomes unrestrained and hyperactive.
Because yang is inherently rising and expansive, this excess heat and kinetic energy rushes upward to the head.
Manifesting as the classic hypertensive symptoms of flushed face, tinnitus, throbbing headaches, and vertigo.
It's a brilliant allegorical mapping of sympathetic nervous system overdrive. But TCM also attributes hypertension to physical blockages within the vascular pathways.
Two of the most common pathological factors cited are phlegm and damp accumulation and blood stasis.
These concepts describe tangible changes in the viscosity and flow dynamics of the blood and interstitial fluids.
Phlegm and dampness in TCM typically arises from poor dietary habits and weak digestion, the spleen system failing to properly metabolize fluids.
These fluids stagnate and thicken, creating a heavy, sluggish environment.
Mechanically, we can correlate dampness to the Western concept of metabolic syndrome, hyperlipidemia, and water retention.
The cardiovascular system becomes bogged down. The heart is forced to generate higher pressures to push thick, slow-moving blood through a vascular bed that is essentially clogged with heavy metabolic waste.
And the patient subjectively experiences this dampness as chronic fatigue, physical heaviness, and a foggy mental state.
Blood stasis is another critical concept. It refers to a state where the flow of blood is chronically impeded.
Often due to long-standing emotional stress, physical trauma, or the culmination of dampness over time.
The blood becomes sticky and stagnant, and local tissues may become underperfused.
To manage these complex systemic imbalances, TCM utilizes highly specific polypharmacy herbal formulas that have been refined over centuries.
Our sources include a comprehensive 5-year analysis of clinical trials evaluating TCM treatments for hypertension.
And the data shows that the most frequently and successfully utilized formulas are the Tianma-Guteng decoction and the Zheng and Shifeng decoction.
The efficacy of these formulas lies in their multi-targeted approach. Instead of using a single chemical compound to forcefully dilate a vessel, these decoctions use a symphony of herbs.
To address both the root cause, the yin deficiency or dampness, and the acute symptom of rising yang.
The analysis highlighted specific individual herbs that appear consistently across treatments. Like Uncaria, commonly known as Chinese cat's claw, is heavily featured.
In TCM pharmacology, Uncaria is renowned for its ability to clear heat, extinguish internal wind, and calm the liver.
Which directly addresses the hyperactive liver yang rushing to the head.
Another major herb is Acantharies, which is utilized specifically to invigorate the blood, remove blood stasis, and dynamically direct the erratic flow of qi and blood downwards away from the brain.
They also frequently incorporate Poria, or tuckahoe, a type of mushroom that excels at leaching out dampness and supporting the digestive system.
Clearing the metabolic waste that creates vascular resistance. What is truly remarkable about this ancient system is how modern biophysics is beginning to map these concepts to cellular biology.
This is a profound convergence. A recent biophysical paper in our stack, focusing on integrating energy fields in medicine, suggests that these poetic TCM concepts are phenomenologically identical to Western molecular biology.
The TCM diagnosis of blood heat and the resultant blood stasis map directly to the Western pathophysiological cascade
of chronic autonomic nervous system dysregulation leading to severe oxidative stress, localized inflammation, and ultimate endothelial dysfunction, the physical damage to the arterial walls that precedes atherosclerosis.
The ancient practitioners were observing and classifying the exact same physiological breakdowns we can now view under an electron microscope. They simply utilized the language of the natural world: heat, dampness, wind, and stagnation to describe the macroscopic physical signs of those microscopic cellular events.
So synthesizing this massive amount of data brings us to the ultimate question for you, the listener. How do we actively intervene in this system?
By combining the mechanics of Western physiology, the biophysics of flow, the psychological pathways of the HPA axis, and the systemic balancing of TCM, we arrive at a comprehensive strategy for natural cardiovascular management.
And the foundation of this strategy must begin with modifying the biochemical inputs. The diet.
Diet directly dictates the viscosity of the blood, the inflammatory state of the endothelium, and the generation of that metabolic dampness.
The sources are unequivocal about the standard dietary antagonists: excessive sodium, refined sugars, and saturated animal fats,
Mechanically, excess sodium disrupts the osmotic balance, pulling more water into the bloodstream.
which increases the total fluid volume the heart must pump, directly elevating hydrostatic pressure.
Refined sugars drive insulin resistance and massive oxidative stress, damaging the delicate endothelial lining and promoting arterial stiffening.
And heavy animal fats contribute to hyperlipidemia, forming the plaques that physically narrow the resistance vessels.
But the clinical focus should be on therapeutic additions, not just restrictions. The research strongly emphasizes the cardiovascular benefits of incorporating foods rich in L-tryptophan into the diet.
L-tryptophan is an essential amino acid. We most commonly associate it with the post-Thanksgiving lethargy from eating turkey.
Right, but biochemically, it is the fundamental precursor to serotonin, a key neurotransmitter for mood regulation, and melatonin, which regulates sleep cycles.
By boosting serotonin, tryptophan actively calms the central nervous system, dampening the sympathetic drive and subsequently lowering blood pressure.
You can source it heavily from pumpkin seeds, walnuts, firm tofu, and lean poultry.
However, the sources detail a specific biochemical mechanism required to maximize tryptophan absorption. Tryptophan competes with other large neutral amino acids for transport across the blood-brain barrier.
If you simply eat a high-protein meal, the tryptophan is outcompeted and fails to reach the brain in significant quantities.
The physiological hack provided in the literature is to pair the tryptophan-rich food with a serving of complex whole-grain carbohydrates.
The ingestion of complex carbs triggers a mild, sustained release of insulin.
This insulin causes the peripheral muscles to absorb most of the competing amino acids from the bloodstream, effectively clearing the highway.
The L-tryptophan is left unimpeded, allowing it to cross the blood-brain barrier in high concentrations to synthesize serotonin and calm the vascular system.
The literature also highlights specific functional foods used in TCM for their targeted vascular effects. Celery, specifically consumed as a raw juice, is highly recommended for cooling the liver and lowering pressure.
The Western biophysical explanation for celery's efficacy is its high concentration of phytochemicals called phthalate.
Phthalates have been shown to act as natural, smooth muscle relaxants.
They actively dilate the muscular walls of the arterioles, physically increasing vessel diameter and reducing the systemic vascular resistance.
Additionally, swapping out sympathetic stimulants like caffeine and alcohol for chrysanthemum tea is advised.
In TCM, chrysanthemum is a primary herb for clearing heat and descending rebellious qi, functioning as a gentle, natural vasodilator that counteracts the rising pressure in the upper body.
Beyond biochemistry, the integration of mind-body mechanics is paramount. We referenced the Byrne framework earlier, and the sources highlight a pivotal clinical trial conducted by the Benson Henry Institute at Harvard University that put the relaxation component to the test.
The Harvard study focused on 58 patients who had been clinically diagnosed with stage 1 hypertension,
meaning their resting systolic pressures were consistently between 140 and 159 millimeters of mercury.
Over the course of 8 weeks, these patients were rigorously trained to elicit what Dr. Herbert Benson termed the relaxation response.
This wasn't just telling them to take it easy. They utilized specific, structured protocols. Diaphragmatic breathing focused on extending the exhalation, the repetition of a focused word or mantra to break the cycle of anxious rumination, and mindfulness meditation to observe stress without reacting to it.
The clinical outcomes were profound. By deliberately and repeatedly engaging the parasympathetic nervous system through these mechanical and cognitive exercises, the patients successfully trained their autonomic nervous systems to lower their baseline sympathetic tone.
They achieved clinically significant reductions in their blood pressure, bringing their numbers down without the introduction of pharmaceutical interventions.
Effectively using focused intention to dilate their vascular bed via nitric oxide pathways.
The sources also validate the use of physical movement therapies like Tai Chi and Qigong. What's intriguing is the caution a TCM practitioner in the text provided regarding exercise.
While Western medicine often prescribes rigorous cardiovascular workouts, the TCM perspective warns that high-intensity, exhaustive exercise like marathon running can actually be detrimental for hypertensive patients.
The reasoning is sound from both perspectives. Exhaustive exercise requires a massive, sustained surge in sympathetic nervous system output,
Flooding the body with cortisol and adrenaline. In a system already suffering from hyperactive yang or endothelial damage, this extreme stress can exacerbate arterial inflammation and cause microscarring on the cardiac tissue from overexertion.
Tai Chi and Qigong operate on a different physiological principle. They integrate slow, deliberate physical movements with deep diaphragmatic breathing and focused mental intention.
Mechanically, the gentle muscular contractions act as a secondary pump, enhancing venous return and promoting systemic circulation without triggering the heart-pounding stress response.
In TCM terms, it smoothly circulates the qi in blood, breaking up stagnation while nourishing the yin.
We must issue a critical, unequivocal clinical caveat here, as strictly outlined in the medical literature we've reviewed.
Right. While these integrative and natural methods are highly effective, a patient must never abruptly discontinue prescribed antihypertensive medications to pursue them.
The biophysical danger of combining these modalities unsupervised is severe.
If a patient is taking a pharmaceutical calcium channel blocker or beta blocker that artificially lowers their pressure, and they simultaneously begin taking high doses of Uncaria or practicing intense vagal nerve stimulation, the hypotensive effects compound.
The stacking of these mechanisms can induce a sudden, dangerous drop in systemic pressure acute hypotension.
As we learned from the critical closing pressure data, if the MAP drops too low, cerebral perfusion ceases. The patient will experience severe syncope.
They will faint, which can lead to catastrophic physical trauma. True integrative medicine dictates that these dietary, herbal, and behavioral interventions be implemented under strict medical supervision.
The goal is to slowly correct the underlying systemic imbalances, allowing the physician to safely and gradually titrate the pharmaceutical dosage down as the body's natural regulatory mechanisms come back online.
It is about actively rebuilding the internal architecture of the engine, rather than simply disabling the warning light on the dashboard.
We have traversed an incredible expanse of scientific and historical territory today. We began by reevaluating the fundamental fluid mechanics of the heart, pushing against the frictional resistance of a degrading arterial network.
We zoomed into the skull to understand the exact pressure thresholds the brain requires to keep us conscious.
We shattered the classical models of physics, shrinking down to witness protons, utilizing quantum tunneling to teleport through ion channels at terahertz frequencies, sparking the very rhythm of life.
We analyzed the sweat-inducing stress of pilot candidates to prove that structured relaxation physically alters our vascular geometry.
And finally, we synthesized these modern biophysics with the ancient systemic wisdom of traditional Chinese medicine to outline actionable paths for healing.
The ultimate takeaway for you, the listener, is the realization that your cardiovascular system is not a passive plumbing network. It is an exquisitely sensitive, dynamic interface.
It is a real-time convergence of fluid dynamics, subatomic quantum probabilities, and bioenergetic networks, all inextricably linked to and modulated by your daily psychological and emotional state.
Your blood pressure is the ultimate readout of how you are metabolizing your existence.
I think that entirely redefines how we should approach our own health.
To close out this deep dive, I want to pose a final speculative thought that bridges the most disparate concepts we've covered.
All right, what is it?
We explored how the electrical potential driving the heart relies on the quantum tunneling of wave packets at the subatomic level. We also saw how conscious, structured mental states like the relaxation response can physically alter systemic vascular tone at the macroscopic level.
Following that logic.
Consider the possibility that human physiology is vastly more interconnected across physical scales than we currently understand. If our biology is fundamentally driven by quantum phenomena, and our vascular tone is modulated by focused mental states, could ancient TCM practices like Qigong and Tai Chi, which utilize breath and deep cognitive intention to move Qi, actually be functioning as an evolutionary mechanism to consciously interface with our own quantum biology?
Wow.
Could the subjective macroscopic feeling of calming the liver yang or clearing stagnation actually represent the systemic sensation of optimizing the quantum tunneling probabilities within our cellular ion channels?
That is a staggering concept. The idea that focused mindfulness is actually a form of internal quantum tuning, that is something to deeply consider the next time you sit quietly and feel your pulse. Thank you to you, the listener, for embarking on this incredible deep dive with us today. Until next time, keep questioning the dashboard and keep diving deep.